Hello, my dear learners. As I have promised, I am back with the management of myocardial infarction. So, why is this important to learn? As a physician, we learn and try to apply knowledge on our prescription for the betterment of the patients. But are we following the guidelines properly? After learning I had a clear picture of the management and I would love to share my notes with you all. So, let's swoop in. For the management of myocardial infarction. So within that of 6 hours of the myocardial infarction, the reperfusion of ischemic myocardium occurs. Okay, and that of after 6 hours, the pain decreases and there is decrease in the ventricular tachycardia or the ventricular fibrillation incidence. If the collaterals develop, there is a good prognosis, of course. Now it is said that heart is time. The more it is able to reperfuse itself, or the more we are able to reperfuse it with the lysis or with the PCA at the earlier point, the more is the chances that the heart will survive. Target times in STEMI. So the patient comes with the pain. We know that it is a Levine's sign. It is the first medical contact that is very important. The first medical contact is something that is there is a person who is able to read the ECG, who is able to resuscitate the patient. There is a defibrillator available there and able to manage at the ground level. So a place where the patient is seen by a medical or paramedical personnel who can take and interpret an ECG. Initial interventions like defibrillation can be done, and the time should be for the ECG to be done should be less than that of 10 minutes. This is very important. So the patient comes to a PCI center. Now we need to learn this that the lysis is a second option. Okay. The primary option is the PCI. So PCI, whenever the patient comes to a PCI capable center, the time to diagnose should be less than 10 minutes. That means the ECG point. Okay. And the time to manage or do PCI should be less than that of 60 minutes in a PCI capable center. Now, if the PCI capable center is not there, right, we are very much familiar with a rural area or some places like that. So, patient comes to a non-PCI capable center, estimated time for the PCI is less than that of 120 minutes. That means we calculated with 30 minutes for the time to call ambulance and then shift the patient. So then patient to be referred with the expectation that the PCI will be performed within that of 90 minutes. Okay. So if the time taken is more than that of 120 minutes, then we need to lyse the patient. This is important. Okay. So the patient to be lysed within that of 10 minutes, and for the lysis, there is the newer guidelines have come up that in the ambulance itself, if we do the lysis, very important, we can do it with tenecteplase. Only a 10 milligram IV bolus is required, and then monitoring is required. That's it. So with the bolus, lytic injection, that is the tenecteplase, we should be lysed within that of 10 minutes and as such refer to the PCI center. Okay. And after the lysis, normally when is the ECG to be done? It is 1 hour, right? 60 to 90 minutes. Now, what if the lysis is failed or lysis is successful? If we are trying that hard and the lysis is successful, then we have to do PCI. Okay, either of the cases we need to do PCI. Okay, but the time differs. Now, if it is successful lysis, then PCI could be a pharmacoinvasive PCI and that to be done in 2 to 24 hours. Now, if it is a failed lysis, there should be an immediate rescue PCI. Okay, immediately the patient is taken to PCI. So the initial management, IV fluids in case of RBMI, we have talked about it. Why? Because of the Frank-Starling law, we'll be dealing with it, right? So especially in the RVMI, take the blood for the troponin, right? Then ECG monitoring and defibrillator. O2, when to do O2 support. So in a hemorrhagic stroke, the O2 supply is required whenever 90% or less than that of saturation goes. And in case of MI, the O2 is required whenever less than that of 90%. Remember this as an MCQ. IV opioids for the pain relief. benzodiazepine and anxiety. So yes, of course, patient are anxious, so giving them certain benzodiazepine is okay. It's fine. Coming to the loading dose, very much confusion about it. Let's clear it all. Aspirin 162 to 125, that too. What it is? It is a Disprin, okay? It is a chewable one. It is non-entry coated. Remember this, right? Do not mark answer as aspirin, then yes, you are making a wrong answer. So then we have clopidogrel 300 milligram. Now, if the age is more than 75 years, then it should be 75 milligram itself. Coming to atorvastatin 80 milligram or rosuvastatin 20 milligram. Sublingual nitrate only for coronary vasospasm, that is anginal, then only we are given, otherwise it's fine. So aspirin, clopidogrel and statin, very important. Now also, if the patient is taken for primary PCR, then we need to add 300 milligram of clopidogrel, or we can just omit clopidogrel, right, and add ticagrelor or prasugrel. Now, what is that? It is the ticagrelor is 180 milligram, okay, and prasugrel is 60 milligram to be added. Okay, so we have certain which is called as TIMI3 and MPG3. This is the normal flow. Now, normal epicardial flow is TIMI3 and normal microvascular flow is MPG3. Okay, so TIMI has this grading. So TIMI 0 is occlusion. Remember O for O. 1 is penetration, 2 is slow flow, 3 is normal flow. Okay, so 3 we need to 3 normal flow, occlusion, penetration, and slow flow. Then we have the coronary blindness. That means certain coronaries are not visible, right? Or they are actually culprit, but they are not visible. So mostly it happens in females who are diabetic and middle aged, right? And these vessels are not seen on the angiogram. So this is called as the syndromics. These are the microvascular vessels which are affected. Coming to the thrombolysis, so there is this first generation, second generation, third generation, and neurofibrinolytics. First generation, we have streptokinase and urokinase. We all are familiar. Then we have second generation, that is the altiplase, dutyplase. We have a pro-urokinase. We have the anisoylate plasminogen streptokinase activator complex. Okay. Then the third generation, we have the retiplase, lanetoplase, tenecteplase, and staphylokinase also. Newer one, we have the desmetoplase and alpha-metoplase. So the short actor acting is the altiplase and long acting is the streptokinase. Now there is a much risk with the bleeding with the streptokinase, we all know that. But ICH, intracranial hemorrhage, is very less with the streptokinase. Remember this as MCQ. Then we all have known this mechanism of action. Let's briefly look into it. Plasminogen as converted into plasmin, fibrin, fibrinolysis, and then we have FDP, that is the fibrin degradation products. So the streptokinase is non-fibrin specific. So will act on any of the blood and blood products, so there is increased risk of bleeding. We all know that in the failed lysis, refer to the PCR, we have the rescue PCI for it, and successful it is the pharmacoinvasive. So the young thrombus responds to the lysis better. Of course, we know that there is the heart is time. Okay. Mortality reduction. Aspirin alone, if it is given 23%, these are the trials, and they have seen that aspirin alone decreases the risk of mortality by 23%. Streptokinase alone decreases the risk by 25%, and both decreases by 42%, nearly 50%, right? STK with aspirin, which is given in 6 hours, 53% mortality risk, right? These are certain trials, EMRAS, LATE, FTTP. Beyond 24 hours, there are more risks as compared to the benefit. Okay, so coming to the dosage part, streptokinase, we all know 1.5 million units over 30 to 60 minutes. In our center, give for 1 hour. Altiplase 15 milligram IV bolus, followed by that of 0.75 milligram per kg IV over 30 minutes, and then 0.5 milligram per IV for 60 minutes. Retiplase is something which is 10 units given, along with that 10 units IV, which is 30 minutes apart. Tenecteplase depends upon the weight. If the 30 milligram, if in case of less than 60 kg, 60 to 70 kg, 35, then 70 to 80 kg, 40, 80 to 90 kg, 45, and more than 90, 50 milligram of tenecteplase. So antigenic allergic systemic fibrinogen depletion is marked. Okay, mostly the antigenic part is with streptokinase. So we can see that whenever there is certain tachycardia, along with that of hypotension, we can know that there is certain anaphylaxis going on. Okay. Then there is an absolute contraindication of lysis. Very important. Daily on daily basis we are lysing the patient, and very important to know the contraindications. So any previous intracranial hemorrhage, the first one, then we have certain cerebrovascular lesions, then the known malignant intracranial neoplasms, ischemic stroke within 3 months, except the acute ischemic stroke within 4.5 hours, aortic dissection, active bleeding, if now bleeding diathesis, significant closed head or facial trauma within 3 months, severe uncontrolled hypertension, intracranial intraspinal surgery, streptokinase, which is given within that of 6 months. So these are the absolute contraindications. Coming to the relative contraindications, the history of chronic, severe, poorly controlled hypertension. We all know that patient come with 220 BP, we don't lyse, okay, and first of all we reduce the BP by 180 or so, and then we lyse. Okay, it is true that lysis is directly proportional to increase in BP. The more lysis, the more success of the lysis. But we also know that if the increase in BP is there and also we are lysing, okay, so it is 220 something, then there is increased risk of stroke, right? Significant hypertension at initial evaluation, very important, more than 180. Previous history of ischemic stroke more than 3 months. Dementia, intracranial pathology, traumatic or prolonged CPR, major surgery, recent internal bleeding, pregnancy, active peptic ulcer, oral anticoagulation therapy. This is all and relative contraindication. Problems while thrombolizing the patient. So hypertension, okay, we know that BP monitoring chart, very important, right? All the GRs 1, GR2 are told for a monitoring. Then hypertension 220 by 140, there is increased risk of stroke, increase in the BP, increase in the thrombolysis chances, right? So patient will can have an oozing varicose ulcer, can have loss of consciousness, immediately NCCT brain to be done, then look for the stroke and the hemiparesis and other focal neurological deficits. Pregnancy, we know that it is a problematic condition, better to avoid it. Okay, develop hypotension while thrombolysis. This is also very common. If the patient develops hypotension with bradycardia, that is a good sign of reperfusion. And if it is an hypotension with tachycardia, that is an allergic reaction with STK. Okay. Now, why is there need for anticoagulation post lysis? Because there is certain, which is this is plaque, okay, and this is the thrombus and this is the plaque. So this thrombus will be removed by that of dose, loading dose and lysis, okay. But here the area is still prone for more of the thrombosis, so we do not want that, okay. So that area also, in the hospital stay, while the hospital stay, we give enoxaparin, okay, is preferred. Pre-hospital thrombolysis, as I said, it is a class 1A recommendation now. Lysis in the ambulance, bolus sanitary is given as the first 1 hour is the golden hour. So these are the trial, Captain, Prague 2 and Stream trial. Then we have PCI versus lysis, when to do, how to do and all that stuff. Do not lyse if it is more than that of 12 hours. 12 hours to 24 hours is the ideal for that of PCI. Okay. Primary PCI class 1 recommendation, and then asymptomatic stable patient 12 to 48 hours is actually class 2A recommendation, that is according to the BRAVE trial. More than 48 hours is not recommended, okay, O trial. Okay. So stenting is preferred as compared to the primary PCI. Radial access is preferred over the femoral access. So primary PCI anticoagulation. What are the anticoagulation given by? So why is it important whenever we are stenting or we are doing a PCI? So these are thrombotic materials and these are actually introduced, thrombogenic. So anticoagulation is necessary. So the unfractionated heparin, or we have the enoxaparin or bivalirudin are preferred, and fondaparin is not recommended, right? Culprit or not. So one is a culprit vessel, one is a non-culprit vessel. Culprit vessel, that means in the ECG we can find out that this is the LAD block or this is something which is LCX block or something like that. In a non-culprit vessel, we cannot recognize the artery, but still it is hidden and it is contributing. So when to lyse that a non-culprit vessel? So if the patient is hemodynamically stable, then we have two options. First is the index procedure and then we have index admission. Index procedure, same time as the culprit vessel is centered, and index admission after 3 to 4 days but before the discharge. In case of cardiogenic shock, not recommended. Okay. What are the bailout procedures in the primary PCI? So one is the aspiration of the thrombus, that is not recommended. It is a class 3. And GP2B3A inhibitors, these are actually a downstream therapy. Okay. Then we have a microvascular obstruction. We know that thrombus lies, and then we have some certain microthrombi in the microvessels, and it can cause actually decrease in flow, and then there can be an obstruction because of the microvessel. So in that, GB2B3 can be given. Variants, we have already learned about the variants, two variants. Talking about CABG, when is it CABG done? We say that angioplasty ho gaya hai and all that. So when is it done? So whenever there is a STEMI and there is a certain complications associated with it, okay? So it can be a ventricular septal rupture or something like that. And in the heart, there is a large area which is affected. So that is also a risk for that of the PCI, and we know that the PCI alone will not help. So we have to do CABG. So if it is a failed PCI and a large area of myocardium is under the risk, and we have a STEMI and mechanical complications. So in the STEMI, if it is the CABG is done within that 24 hours, there is a high risk of mortality. That is 15% mortality. Okay. So there is a protocol if it is a failed PCI. Okay. What do? We lyse the patient. Okay. And if the lysis is contraindicated or it is failed, then we can do CABG. Okay. Then we have adjuvant therapy. We all know that after the patient is being discharged, so we give aspirin, we give statin, and we give according to his EF, we give ramipril or something like that. So how to give and what to give? Now, antiplatelet aspirin is very mandatory, lifelong, and then we have clopidogrel, cadmium P2Y12, because that can be given until 1 year. So clopidogrel 75 milligram per day, ticagrelor 90 milligram BD, or we have prasugrel that is 10 milligram OD, right? Statins to be given in all the patients. Then we have atorvastatin, rosuvastatin. If the statin are intolerant, then we have ezetimibe, right? Coming to the ACE inhibitors, all the patients within 24 hours of the PCI, SAVE, AIR, and TRACE, these are the trials, okay? So all the patients we need to give the ACE inhibitors, ARBs. We know that ramipril, we have the lisinopril, captopril. Coming to the beta blockers, for the beta blockers, we have certain contraindication. It is to be given in all the patients because it reverses the remodeling and oxygen free radical damage and everything. So it decreases that. So all the patients are recommended. The contraindications are hypotension, tachycardia, bradycardia, COPD, heart failure. Okay, so this is to be used in caution, right? Mineralocorticoid receptor antagonists, these are not given in all the patients, but in patients who has EF more less than that of 40%, and in heart failure in case of type 2 diabetes mellitus. The drugs are spironolactone and eplerenone. Nitrates only in hypertension, in case of angina, in case of if the heart there is actually a heart failures, then there is no mortality benefit, so it is not given in all the patients. Nitrates. Calcium channel blocker only when the beta blockers are contraindicated and not working, then okay. Magnesium is said to stabilize the VTAC, and so it can be given, right? Glucose control less than 180, so HbA1c and everything to be done. Okay, so we have already discussed if the BP is more than that of 220, and then there is the NTG drip or the Lasix are given, whatever is preferred in your sector, and then mostly the less than that of the 180 per 100, and then we can lyse the patient. So we have primary ventricular fibrillation within that of 24 hours of the MI. So that is actually not thing to worry. No specific treatment as it indicates abnormal electrical activity, but there is a recurrent EF. Of course, we need to give a Almirone with that of PCI. For the ICD to be inserted, always wait for 45 days, right? And after 12 hours of the symptoms, no lysis, primary PCI. We all know that. So until that of 12 hours, we need to do it, right? MI and elderly, very important because they have comorbidities. Okay, age is a factor. Okay, then they have atypical symptoms. Okay, and there is even though we are initiating lysis and everything, so there is a risk with that. There is an increased risk of associated complications also, and it is not so much guaranteed that the patient will reperfuse, right? So there is no upper age limit with respect to reperfusion. Okay. Now, very important. Even if the patient arrives to you and his ECG says there is a Q wave in it, and the patient has come within that of 1 or 2 hours to you, Do not think that Q waves have arrived and so lysis cannot be done. If the patient has ST elevation significant enough, and if there is a chest pain to it, do not think that Q waves have arrived, so no lysis. Q waves will arise even within 1 hour, right? So we have to focus on the symptoms and on the elevations, okay? And so we need to lyse the patient in between of 6 to 12 hours. There is a Cangri law that is acts within that of 5 minutes, and who have not received P2Y2, so they can be a beneficial one because it has faster action. Then, what are the marker of success? So coming to the prompt resolution of the pain. Now, pain can disappear within hours. Okay. Now, if it is within that of 4 hours or something like that, early pain, then we know that patient has reperfused. But if it is a late pain, that means that myocardium is dead now. That's why the pain has reduced. What are the problems with the pain? It is a subjective one, right? And certain MI will not be will have atypical symptoms, will not have pain, chest pain. Pain perception is subjective. The analgesics are given, and then precardial paralysis, it can be a social precardial pain also. So it is similar. Achievement of electrical and hemodynamic stability in a patient who was previously electrically and hemodynamically unstable, right? This can be a marker of success. We see the elevations, it should be more than 70% reduced. If it is less than 50%, fail lysis, okay, rescue PCI is done immediately. There is a formula to it, sum of all the ST elevations before and some divided by sum of all the ST elevations after. So that will lead to a percentage, and it should be more than 70%. Post-lysis ECG within 1 hour. Then we have the marker of success as the early T wave inversion. See, T wave inversion come, but it is in later part. If it is early T wave inversion, that means it is a marker of reperfusion. Early peaking of cardiac enzymes. This is also very important, right? Sinus bradycardia hypertension, we have already seen that. Late diastolic VPC and disappearance of atrial fibrillation with that of bundle branch block. Accelerated idioventricular rhythm is also a sign of reperfusion, right? So remember this ECG. So that's all for today. I hope you have enjoyed this video. I'll see you next time. Bye.